Hello, do you hear me now well? Do you hear me? Hello?
Yes, I hear you perfectly, Mehsen.
That's fine. Everything is okay now? You see everything on the keyboard? Everything is shown?
Clear. It's clear.
Yes, thank you for everybody attending our webinar today. Shukran, Dr. Ali Naqash. Thanks a lot, Dr. Ali, and for all accompanying persons. We are talking actually about the menorrhagia and what happened exactly in Iraq and how we are managing menorrhagia in Iraq. There's just a few terms everybody should know about how we usually define menorrhagia and what we mean by each term. Menorrhagia means excessive bleeding in amount and or duration. That means either the bleeding in amount is big or the duration is more than 7-8 days or combined. Polymenorrhea means the cycles is too frequent. That means came every 21 days. This is usually because of shortening of the proliferative phase of the menstrual cycle, lead the cycle to be more frequent. But there's another term called polymenorrhagia. That means the cycle is excessive in amount and duration. That means it's too frequent cycle and at the same time heavy cycle. All these menorrhagia, polymenorrhea and polymenorrhagia are usually cyclical. The acyclical one is metrorrhagia. That means the cycle is completely irregular, but still is heavy in amount. There is a term called intermenstrual bleeding. That means the bleeding in between the cycles. And this is because of different factors usually. Hypomenorrhea means scanty means the amount of the bleeding is a small amount. And oligomenorrhea means the cycles is too, big gap between cycle and other every 35 days or more. Now, I'm discussing actually the subject separately. I'm not going into organic causes of menorrhagia because as we know that organic causes usually managed by according to the cause. Let's suppose because of pregnancy, because of a tumor, because of fibroid, because whatever. Usually treated separately. We are talking about mainly menorrhagia because of dysfunctional uterine bleeding. We have the organic causes. And organic causes here mainly either pregnancy complication like miscarriages or ectopic pregnancy or hydatiform gestation, a tumor like tumor بالاوvaries, tumor بالuterus, tumor everywhere ممكن يكون cause for the bleeding, adenomyosis, endometriosis, or extragenital. That means something related to either menorrhagia because of bleeding disorders like von Willebrand disease or idiopathic thrombocytopenia purpura, or due to any bleeding disorder that could be a cause, or hormonal because of hypothyroidism or hyperprolactinemia, all may lead to a bleeding, or certain systemic diseases like hypertension, diabetes. Affected women, they might got bleeding. This is not our subject actually. We are not looking for this. To define dysfunctional uterine bleeding is abnormal uterine bleeding in the absence of organic pathology. اللي هي ثلاثة, mainly three: pregnancy, infection, and the tumor. So a bleeding of uterine in origin and the exclusion of these three things, a pregnancy, tumor, infection, considered as dysfunctional uterine bleeding. How would we classify uterine bleeding or dysfunctional uterine bleeding according to the pathophysiology? We have primary dysfunctional uterine bleeding. That means the bleeding primarily because of uterine in origin, because of genital tract problem, of uterine, mainly of uterine in origin. اكو رقم اثنين هو secondary dysfunctional uterine bleeding. قبل كان يسمى secondary and iatrogenic. Now all these combined together, secondary and iatrogenic, extragenital causes for bleeding, like medical problem as I mentioned, or the use of intrauterine contraceptive device or injectable Depo-Provera injection types of contraception. هذا اللي يسموه iatrogenic, or secondary dysfunctional bleeding due to medical problems مثلا, or bleeding tendency. All these are considered as secondary dysfunctional uterine bleeding. We have a classification of dysfunctional bleeding according to the cycle. اكو عندنا شيء اسمه اما dysfunctional type bleeding is ovulatory type of bleeding, or anovulatory, or corpus luteum abnormalities. This is another type of, we'll go through when we reach the slides. Now, what are the extent of investigation to be done? The extent of investigation to be done to say this is a dysfunctional uterine bleeding. أول شيء abdominal pelvic examination, ultrasound examination, and endometrial sampling. Ultrasound يشمل abdominal and vaginal ultrasound, abdominal pelvic examination, and endometrial sampling. All these, if we don't find the cause after we use these three methods, so this is a dysfunctional, we label the problem as dysfunctional uterine bleeding. Then what is the then if it is not due to pregnancy and not due to tumor and not due to infection, so what could be the cause then? There is different theories explain the occurrence of dysfunctional, like number one, an increase in the size of the endometrium, an increase in the surface area of the endometrium. Definitely small size uterus, not like big size uterus. More surface area of the endometrium, more shedding, more bleeding. This is one. Two, an increase in the vascularity of the uterus. Certain uterus with big vascularities, a lot of vascularity in the uterus. Acute uterus, small vascularity, big vascularity. ممكن هل زيادة, this increase in the vascularity of uterus could be the cause of the bleeding. Number three, an increase in the elasticity, decrease, sorry, in the elasticity of the vessels, decrease in tunica media, which cover the vascular, usually in the mid vessels, there is tunica media. This is elastic, usually replaced by fibrosis and easily fragile, easily fractured, easily fragile, sorry, easily rupture these vessels. If ruptures happen, then the bleeding will happen. Number four, an increase in the lytic substance as compared to the coagulative substance. There is more excessive fibrinolysis, and hence the treatment of comes the benefit of using epsilon amide caprylic acid in the treatment of bleeding because of excessive fibrinolysis. And number five, there is disbalance between the prostaglandins. Two types, we have two types of prostaglandin. The group of prostacyclin اللي هي vasodilator, and the group of thromboxane اللي هي vasoconstrictor. Increase in the prostacyclin in correspondence to thromboxane. An increase in the prostaglandin E2 and I2 اللي هي dilator in correspondence to prostaglandin F2 alpha اللي هي constrictor, and hence this will lead to more bleeding. طبعا it's important to understand this point because the treatment came after يعني the benefit of treatment, how we use the treatment. Usually it is, we should understand this subject before we start treatment. Now, anovulatory bleeding, we classify them to three: anovulatory or corpus luteum abnormality or ovulatory bleeding. هذا اللي حكينا عليه من البداية. Anovulatory bleeding, each of these three terms, either overactive or underactive. To understand the subject properly, each one of these subjects either underactive or overactive. Anovulatory bleeding, to start with overactive, there is excessive production of estrogen because the cycle are anovulatory. That means there is no corpus luteum, no progesterone. If there is no progesterone, no corpus luteum, that means because of no ovulation, there is no corpus luteum, no progesterone secretion, and hence there is excessive production of estrogen. This increase in the level of estrogen lead to hyperplastic changes in the endometrium. Excessive proliferation of the endometrial glands lead to more proliferation, and hence the vascularity cannot cover this hypertrophied endometrium. This will result in short duration of amenorrhea followed by heavy bleeding. It is similar to ectopic pregnancy. The only difference is that in ectopic gestation, usually pain precedes the bleeding, while in patient with anovulatory overactive, we call it metropathy hemorrhagica, there is short duration of amenorrhea followed by heavy bleeding. Why there is heavy bleeding? Because there is excessive growth of the endometrial gland, and this excessive growth of endometrial gland will not lead to to cover the vascularity of this hypertrophied and hence will result in bleeding. Underactive, there is a small amount of estrogen secreted. This is what we call the threshold bleeding. And this is diagnosed by finding low level of estrogen. And estrogen important in building the endometrium. After ovulation, there is a sloughing of the endometrium. The uterus need to be healed. The proliferative phase, the proliferative phase is the cause for healing of the endometrium. If the patient have got low estrogen level, threshold bleeding, this will lead to unhealed endometrium properly and hence also result in bleeding. This is the type 1 ovulatory bleeding. The second thing is that abnormal corpus luteum or corpus luteum abnormality. Defined into overactive, underactive. Overactive, that means prolonged corpus luteum activity. The prolonged corpus luteum activity, the corpus luteum remains active, extending to the new cycle. When we took a biopsy from the endometrium, we find both secretory and ovulatory, secretory and proliferative, both find in the same cycle. Why? Because there is prolonged action of corpus luteum. The underactive part of corpus luteum abnormality is the corpus luteum insufficiency. This is the corpus luteum insufficient to cover the 14 days, insufficient to cover the 14 days, and hence result in what we call pre-menstrual spotting. This is usually happen 5 days before proper flow, before menstruation. There is corpus luteum insufficiency. That means the corpus luteum is inadequate to cover the whole luteal phase of the menstrual cycle, and hence will result in pre-menstrual spotting. The ovulatory type of bleeding also divided into overactive and underactive, abnormal shedding and abnormal ripening of the endometrium respectively. Abnormal shedding of the endometrium, abnormal shedding of the endometrium, there is more than one graven follicle ripen at a time, resulting in speedening the growth of the endometrium. That means this will shorten the proliferative phase of the menstrual cycle, and hence the cycles became too frequent. And that's what we call polymenorrhea. It is also part of menorrhagia. Why? Because the cycle is shortened every 21 days, every 18 days. Why? Because of shortened proliferative phase. Why the proliferative phase shortened? Because there is excessive production of estrogen from more than one graven follicle ripen at a time, result in shortening of the proliferative phase. The underactive, no, there is a small few follicles formed, and hence there is slowly growth of the endometrium, slowly growing. This result also, and because unrepaired endometrium, well, by proliferative phase, this will also result in a bleeding. Now, how would we investigate patient with, this is what will happen in our country exactly. I'm not talking in general. How would you investigate? Usually we start with the simple investigation. When we ask about investigation, we always say either non-invasive or invasive investigation. The non-invasive investigation include complete blood picture, hormonal profile, mainly prolactin and hypothyroidism, because hypothyroid women tend to be menorrhagic. That's why we should look for the hormone, for hormone assay. We should liver function test. We do it because the liver derangement is a cause for problem. Renal problem also important in the cause of menorrhagia. Diabetes, because diabetes also is a cause of menorrhagia. All these are ultrasound examination, transabdominal to exclude abnormalities, and transvaginal ultrasound also done to exclude abnormalities. And sometimes you find subclinical pregnancy, subclinical infection, subclinical endometriosis, subclinical fibroid, all may be discovered by a proper ultrasound and MRI scanning. Ultrasound are كلش important to detect abnormalities in the uterus, possibly not discovered earlier in the old ordinary ultrasound. The invasive investigation mainly DNC. طبعا إذا نقسم we divide patient with dysfunction according to the age. طبعا تعرفون younger age group adolescent, because they are virgin, so we cannot do DNC for them. DNC is better to be done between 20 to 40 days, but after 3 months a trial of a treatment. The patient should have postponed 3 months trial of treatment by different method of. We will take it in the. We will mention it in the last in the few slides coming. So the invasive investigation, mainly DNC. DNC usually done either by Sherman curate, this is what happened exactly in our country and our, I would say, south of that, or Vipra aspirate, especially in those with very tiny cervix, you cannot pass through easily. Even hysteroscope sometimes difficult to pass through this small pin-size cervix. So invasive method is better to be postponed in 20 to 40 days, but after 40 years, sorry, 20 to 40 years, but after 40 years is mandatory. Usually, if we did an ultrasound for the patient, and the ultrasound result says that the thickness of the endometrium more than 12 millimeter, then diagnostic curettage is mandatory for these cases. Diagnostic curettage is mandatory because of the possibility you may discover an abnormality, either complex hyperplasia, which need interference, which need other interference other than the simple procedures or method we do for them. So we need to have endometrial sampling, sometimes done by hysteroscopy. In hysteroscopic diagnosis, it is in a few hospitals, actually in the tertiary center done in Basra University and Basra Maternity Hospital. They usually took biopsy from the possible affected area. Because as we know, if we did the DNC blindly, possibly the success rate to find abnormality is 65%. 65% of cases of DNC, you may miss the case. If you did the DNC for any reason, you may don't take the biopsy from the affected lesion. That's why DNC is not so of benefit for the patient with the menorrhagia, to look for the exact cause for menorrhagia. Now, for the medical treatment, we have the general measures. Usually, especially those patients who are usually those young age group, adolescent, virgin, single, usually you let them to have what we call the menstrual calendar, just to pay their attention. They calculate the amount of the cycle and how many days, how many pads they usually use. You just correct their anemia. You just reassure them that nothing they have. After you exclude organic pathology, of course, you don't say you don't have, you don't to be worried about your symptoms unless you exclude all organic causes like ovarian cyst or functional ovarian cyst, or I would say certain tumor producing, estrogen producing cysts. You have to exclude them. Otherwise, you don't need to disturb those patients. Usually, you reassure them and psychological support. That's fair enough for treatment of patients with dysfunction among young age اللي هم بالنسبة لنا single. other measures اللي هي non-steroidal anti-inflammatory. This usually used like mefenamic acid or aspirin. عادة تعطى for patient with where we possibly the cause, as we mentioned in the pathophysiology, we said that there's prostaglandin deficiency and prostaglandin F2 alpha and an increase in the prostaglandin I2 and E2, which is a prostacyclin. Hence, the importance of antiprostaglandin schemes as treatment. Epsilon amino caproic acid given for those patients with the possibility of excessive fibrinolysis. الهرمونال ثيرابي نجي دا ناخذ بالتسلسل في start with the androgen. We don't use androgen رغم انه الاندروجين is very good, it's supposed to be very good as treatment, but because of its virilizing effect, we don't use androgen alone. If we took estrogen is of benefit only for those cases with threshold bleeding, when the patient have got atrophic endometrium. I have just mentioned what type of it is, anovulatory type, underactive of underactive part of anovulatory dysfunctional type bleeding. When there is deficiency of estrogen helps. Maybe this is the only condition where estrogen you use safely in those patients with the threshold bleeding. Number 3, the progesterone therapy. The progesterone therapy actually divided into either oral or injectable. Oral هو النورethistرون or بالماركت يسموه البرايموليوتين. البرايموليوتين او نورethistرون. This is given in different ways. The first way, to arrest the bleeding.
Γιγάκι, δεν σ' ακούω καθόλου, παιδί μου.
Yeah.
Ναι, λίγο.
To arrest the bleeding, usually we give dose of 20 to 30 milligram. That means 2 taps thrice daily to stop the bleeding. This is immediately patient came with menorrhagia, want to stop the bleeding. But you told her to take 2/3 primary, and that means 30 milligram of norethistérone for 2 days, and then you start cyclical. The second thing is that we use the progesterone from 20 to 25th day of cycle for those with the premenstrual spotting, for those with corpus luteum insufficiency. The third regime is to use the progesterone from 16 to 25th of cycle, and this is specifically for those with patients with menorrhagia hemorrhagica, because patients with menorrhagia hemorrhagica, they have anovulatory type of bleeding, overactive type of anovulatory bleeding. They have no corpus luteum, so you need to support that you need to overcome the excess estrogen by use of progesterone from 16 to 25th day of cycle. Other measures is cyclical. We use estrogen and progesterone combined. Is given from 5th to 25th day of cycle, or progesterone alone from 5th to 25th day of cycle. This is for cycle regulation, and especially for cases of menorrhagia, completely irregular cycle. You need to regulate that cycle. Those patients who don't want fertility, possibly you may use contraceptive pills. It is to regulate the cycle and at the same time to decrease or to stop the bleeding or to decrease amount of the bleeding. Other measures, 17-ethinyl testosterone, what we call danazole. Usually this is given as 200 milligram thrice daily or 4 days or 4 times, that means 800 milligram to stop the bleeding. But this is need to be, because as we know, this is anti-estrogenic and act on the hypothalamic level, so it needs time to act. Other measures هو 19-ethinyl testosterone. I'm sorry سريع على مود لا أتجاوز النص ساعة يعني. الأثينايل testosterone هو 19-ethinyl testosterone, gestrinone. This is also used in our country to stop the bleeding. It's also helpful, but it is more expensive than danazole. LHRH analogs, because it should be given in rhythmic form. That's why it is difficult to be used. It is not easy to be used. In difficult cases, possibly, we use the LHRH analogs. In difficult cases where the treatment is not simple. Now, other measures هو الsurgery. If we took a surgery as a subject, actually, this is depend on the case. Let's suppose the result of DNC for those who are above 40 years of age, say complex hyperplasia. Then if she completed her family, it's better to do total abdominal hysterectomy, whether to preserve or to keep or to remove the ovaries. Usually the cut age, we think that 47 years. This is what happened exactly. That's problem?
Can you please mute yourself, please? We are in the middle of a lecture. Mahsen, carry on that.
Yeah, thank you. So surgery for those where the result came, say there is a complex hyperplasia, then you have to discuss the problem with the patient. And if she completed her family, we do total abdominal hysterectomy, whether to remove or keep ovaries. This depends on the age of the patient. Usually the cut age in our country is 47. Above 47, preferably you remove the ovaries, and before that, you may discuss the problem with the patient. We have the transcervical endometrial resection. Now it is used in our country by hysteroscopic resection of the hypertrophied endometrium. This is depend on the patient desire. Some patients, they refuse to do hysterectomy. Certain ethnic group, they refuse to do hysterectomy. And in certain cases where anesthesia would be, as you know, the anesthesia is, the patient is unfit for anesthesia, especially in among old age group. This is done by hysteroscopy. It is done nowadays. Uterine artery embolization. Actually, that was before, I would say, before 10 years, when we are facing problem with multiple uterine fibroid and inoperable cases, those with the previous 2 or 3 scar, and they have multiple uterine fibroid. Those patients, we arrange for them with the radiologist in Lebanon to do uterine artery embolization. I myself arranged with Dr. Abbas al-Madani. I think he's working in American University of Lebanon. And actually, he did for many patients with uterine artery embolization, but it wasn't so satisfied, actually, the result. I don't find a good satisfied result. Nowadays, it is done in Al Musawi Hospital and done by one of our junior, excellent junior, Dr. Asama. He did the uterine artery embolization, and we sent many patients for him with the patient not responding to simple measure, and they don't want to remove their uterus. If they want, that's simple for us, but they don't want to. So we think of uterine artery embolization. Radical treatment, this is what we call total abdominal bilateral saphengoophorectomy. Radiation to the ovaries, we don't use it actually in our country. It is written, but actually in those patients with, if they have a combinant condition like malignancy, also, you may use this as a measure to stop the working, of ovaries, as you know, because of most of them, they are estrogen dependent. If you stop if the ovaries stop action, definitely the patient will have no any bleeding anymore. This is my last slide. I'm sorry because I got in a hurry because I have half an hour to present my talk. Thank you for your nice presentation, and I hope I cover major things in my subject. Thank you.
Professor Bach, it was our pleasure having you today. Absolutely,
Thank
very
you.
nice presentation.
Thank you.
I'm glad that there is a first generation ablation in Iraq, which is the transcervical resection of the endometrium you mentioned. And also you mentioned about the uterine artery embolization, which is really impressive. You know, I didn't know that in Musawi they do it really. Professor Bach, can you stop sharing now so that we have the screen? Can you stop sharing now?
Sure.
And you like sharing all the time. I know you want, you want the screen for yourself. But very nice having you with us. Please stay with us. The next speaker is Mr. Harris Phillip. He is a very long friend of mine. We first met probably in 1999. We were both poor registrars trying to find our way. He did very well. In fact, he passed his membership before I did. And then he went and trained in urogynecology. And within a few years, he became a consultant. And he been a consultant now in the UK for over, I would say, maybe 17, 18 years. So I found him is the best person to can talk to you about the way menorrhagia be managed in UK. So Harris, where are you? I cannot find your picture anywhere. Are you still with us?
Yes, I am.
Yes, good, good. Here you are. Here you are. When you speak, then we can see your picture. So this is Harris Phillip. Harris is multi-talented. He's a writer. He published a few books, some of them behind him. He got many other things to publish, in fact, and he got his theory about management of menopause as well. So he's going probably to publish that as well in the next few years. Harris, we are really honored to have you with us. Please fire up now. Share your screen first.
Okay.
Yeah, we done that before. I hope you haven't forgot how to do it. Take your time. Take your time. We're all looking at you. This might be daunting, you know.
All right.
Okay, but you get there. So go to the green knob called Share Screen. And have you opened your presentation in your laptop?
Yep.
So you should find it. Once it's open and you are co-host, yes, something happening. Yes, brilliant. This is the orange presentation of Mr. Phillip. I leave it to you, Mr. Phillip, the platform for you.
Thank you, Professor Ali, for inviting me to give a talk on this webinar this evening. I am actually very pleased with what I've seen thus far, And without further ado, I'll just delve into my topic. The topic as invited to talk about was modern management of menorrhagia. And I have a subtitle named Shrubs in the Flood. One wonders where did that come from? Shrubs in the flood. It actually comes from the fact that menorrhagia can be or is described as heavy bleeding. So with shrubs, we're talking about how we can control the flood, how we can control the loss. So most of the topic will be focused about how steps we can take to reduce blood loss. I have a series of objectives that I am expecting us to be able to acquire by the end of this presentation. Among them, probably a little simple, we should be able to define menorrhagia. We should be familiar with the signs of menorrhagia, be aware of causes of menorrhagia, recognize that the approach to management is age dependent, and know useful shrubs to control the flood. The anatomy of the topic in terms of what do we mean when we talk about menorrhagia? Menorrhagia essentially is heavy menstrual bleeding. It is also referred to as hypermenorrhea. It is a medical term used to describe menstrual periods with abnormally heavy or prolonged bleeding. So classically, menorrhagia is defined as excessive uterine bleeding occurring at regular intervals or prolonged uterine bleeding lasting more than 7 days over several cycles. To put things in perspective, I have put together a volume of loss of blood loss that would be considered normal for most women. An average blood loss would be between 30 and 80 mils of blood loss per cycle. So what constitutes a heavy period? We do not expect a woman to walk around with a little measuring cylinder, measuring how much blood loss she has over one period. Because I said to you earlier that the average blood loss is between 30 and 80 mils of blood. So do we expect a woman to walk around with a measuring cylinder, measuring how much loss she has had? Of course not. I have some suggestions as to how she can determine whether or not she is having heavy bleeding. For example, if a bleeding lasts for longer than a week, we consider that to be excessive bleeding or menorrhagia. If she needs to use more than one pad or tampon within an hour, that will also qualify as heavy bleeding. If she needs to use double protection, maybe a tampon in addition to a pad or sanitary towel, that could also constitute heavy bleeding. And finally, if she continues to pass large clots, and when I say large, I'm giving you an idea as to the diameter we're looking at. We're looking at a diameter of about 2.5 centimeters or 1 inch as the size, the lower limit of a blood clot we consider large. Now, let's suppose you have been bleeding heavily, but you don't recognize it. We have ways in which the body tells us that there's something wrong. We talk about the symptoms associated with menorrhagia. We talk about tiredness, easy fatigability, shortness of breath, dizziness. Now, I am not for once indicating that you only have those symptoms if you're having heavy bleeding. There are several causes for those symptoms. But if you know you're having heavy bleeding of the type I described earlier, then with those symptoms, one would start to think of, hey, am I losing too much blood? Is my hemoglobin low? Am I anemic? Because all of those are signs of anemia. Now we look at causes of menorrhagia. I found that the best way to describe menorrhagia is in terms of age groups. For example, around the menarche, that's just after a woman first starts having periods, the most common cause would be a hormonal imbalance. There's also dysfunctional ovaries, medications, thyroid dysfunction, or receptor immaturity. What do I mean by receptor immaturity? For that, we talk about a lock and key hypothesis. Basically, if you're trying to open a lock and the key does not fit appropriately into that lock will not open. But when the key fits directly in the lock, as seen here, then you have a binding of the hormone to the receptor site, and then the effect. Okay, so that's what tends to happen as far as the lock and key hypothesis is concerned. Now we look at age groups between 20 and 30 years of age. We talk about medications, thyroid dysfunction, adenomyosis, cervical disease, and uterine structural abnormalities. Now for clarification, I've brought you a little picture of a uterine abnormality. On the left, we have a normal shaped uterus. On the right, we have what we call a bicornuate uterus. Simply looking at those two structures, you realize that the bicornuate uterus has a larger surface area from which endometrium has to be stripped during your periods. So therefore, there'll be a greater risk or chance of having heavy bleeding or prolonged bleeding. So this is one of the factors that may be responsible for menorrhagia. In the 30 to 40-year age group, we talk about thyroid dysfunction. Then we talk about organic lesions like fibroids, polyps, endometrial hyperplasia, medications. Bleeding disorders are also common in all the age groups. They are also a cause from the time you reach menarche up till the time you enter your menopause. However, neither the Royal College of Obstetrics and Gynecology, that's the college in England, which governs obstetricians and gynecologists, nor the American College of Obstetricians and Gynecologists recommend routine testing for bleeding disorders in patients complaining of menorrhagia. There's also a condition called adenomyosis, which can cause heavy bleeding. Essentially, it is the ingrowth of the endometrium into the muscle or the myometrium of the uterus. The effect is it creates a larger surface area from which myometrium must be stripped off, hence leading to a greater amount of blood loss during the menstrual cycle. Additionally, we talk about cervical disease. If there is any type of cervical lesion, even cervical polyp, that may lead to prolonged bleeding. Then we talk about progesterone hormone deficiency, which essentially was mentioned by the former speaker when he talked about corpus luteum insufficiency. And again, uterine structural abnormalities, as indicated previously. In the 40 to 50-year age group, we talk about organic uterine lesions, polyps, fibroids, endometrial hyperplasia, and even endometrial cancer. There's also dysfunction of the hypothalamo-pituitary-ovarian axis. Bleeding disorders also show up its head, adenomyosis, and cervical disease. Again, progesterone hormone deficiency and uterine structural abnormalities. So when you look at these various age groups, you find a type of recurrence of possible causes for heavy bleeding. Now, how do you investigate it? This is a bit of a busy slide, but let's just tolerate it as best as you can. In the perimenarcheal time frame, that is between a young girl just getting into having a period, what you call menarche, to about 20 years of age, the investigations and inquiries would be focused almost entirely on non-gynecological causes, such as thyroid dysfunction, bleeding diastasis, or use of specific medications through routine screening for bleeding disorders in all women with menorrhagia is not recommended. I cannot emphasize that strong enough, because everybody who walks through your door complaining of heavy bleeding, you're not going to start doing blood tests on them to see if they have any coagulation deficiencies. Usually there's a history before they meet you, but if they present to you with a simple complaint of menorrhagia, the advice is not to just go looking for any bleeding diastasis. In the age group between 20 and 30 years, investigations and inquiries would be focused on medications, thyroid dysfunctions, adenomyosis, cervical disease, fibroids. Although rare in this age group, it is not unknown. In fact, the earliest or the youngest patient I had to do a hysterectomy on was age 21. And that was the second time of an attempted myomectomy. She just wasn't stopping bleeding, so we had to take the uterus to save her life. So although fibroids are rare in this age group, it's not unknown. Further investigations include ladies with age group between 30 to 30 years of age to menopause, and I'll interjected the average age of menopause in this country is 51. The focus is on thyroid dysfunction of the hypothalamo-pituitary ovarian axis, bleeding disorders, adenomyosis, cervical disease, progesterone hormone deficiency, endometrial hyperplasia, endometrial cancer. Those are all plausible causes of menorrhagia. But because of the greater incidence of sinister pathology in this age group, the focus of the investigation is almost entirely on the gynecological organs, the ovaries, the uterus. You know, you're looking to see if there are any benign lesions like fibroids or polyps, or ovarian disease, ovarian tumors, those kind of factors which would lead to heavy bleeding. Now we talk about shrubs in the flood. In other words, what treatment modalities would you employ for individuals presenting with heavy bleeding? Basically, we talk about the treatment modalities in terms of medical treatment versus surgical treatment. Medical treatment is almost exclusively used in the younger age group. That's in the perimenarcheal individual between 13 and 20 years, essentially because of receptor immaturity. A number of suggestions have been made in the past. The use of NSAIDs. We talk about Punstan, also called mefenamic acid, and it's reputed to reduce blood loss by 20%. Alternatively, or in conjunction with mefenamic acid, one can use cyclocarpone or tranexamic acid. This is an antifibrinolytic agent. The advice would be to give 1 gram every 8 hours for 4 days, a maximum of 4 days. And the time frame at which you start your cyclocarpone would be the days of the heaviest flow. So if a woman's heaviest flow is on day 3, you don't want to start the cyclocarpone on day 1. You start on day 3, and she continues day 3, day 4, day 5, and day 6, and stop. Used properly, it is supposed to reduce your blood loss by about 40%. As to whether or not this actually works, your experience may tell you something differently. One agent which I find most definitely works would be the use of progestins. But again, that has to be used appropriately. The time we tend to use it, if we use oral progestins, would be between day 5 and day 26 for 21 days. Now you may ask yourself, why day 5? A normal cycle would be up to 5 days. So you allow the woman to bleed for 5 days, and then you jump in, you stop it, and then you use your progesterone for the next 21 days. After you stop after 26 days, her bleeding would occur, but much lighter. That oral progestin is used in patients who would want to maintain their fertility. Okay? Now, there's talk that contraceptions can be used. We talk about medranstol, northisterone, ethinyl, estradiol, neogestimate. There's, however, insufficient evidence to assess the effectiveness of monthly oral contraceptive pills for reducing menorrhagia. However, taking it from a man, I continue to struggle as to why a woman needs to have a period every month. Can she not have 4 periods per year? You know, we could give her, we could try cycle. The combined oral contraceptive pills, that is, give her a stack of 3 months back to back to back, and then she takes a break, she has a bleed, and then she gets back to back to back, and then she has a break. So in that scenario, the woman would have only 4 bleeds per year. Now you may say, well, hey, everyone likes to feel like a woman wants to have a period every month and so on. To me, it's intrusive and messy, but to each his own. Options would involve, other options involve the use of the implanton or Nexplanon, which is a contraceptive device that you place under the skin. There's also the use of Depo-Provera, which is an injection that is used as a form of contraception. It is ill-advised to use Depo-Provera in the younger age group for the simple reason, if a woman is trying to, or is thinking of a family, say in the next 2 to 3 years, if she uses Depo-Provera, we cannot tell her with any degree of assurance when her periods would return. In other words, after you stop your Depo-Provera, there is a latent period during which the ovaries tend to recover before the cycles resume. Hence, For that reason, I think it's ill-advised to use Depo-Provera on the younger age group as a form of contraception or to control heavy bleeding. In a patient who is parous, that who has had children before, we would think in terms of using the Mirena intrauterine system. It's an effective therapeutic tool for women who want to preserve the fertility and avoid the morbidity of surgery. This is an effective long-term option, and it is 94% reliable. Just by way of diagrams, this is a surgical picture of the Mirena in place. She's a long string, which has to be, some of it has to be left coming from the cervix so it can be easily removed. It has two arms, which are very flexible. So by pulling it through, the arms close on themselves, and it's easily gotten through from the uterus. A frontal view would be this. So the Mirena should be placed gently against the fundus of the uterus, and the arms reaching across towards the ostium of the tubes. That's the appropriate position of the Mirena. Then we talk about surgery. Question is, why do we treat patients with menorrhagia? This leads to a substantial improvement in the quality of the patient's life. Obviously, if a patient is losing several days from work because of heavy periods, or is always dizzy and tired and so on, she needs something to be done. And we can do something about it. So what approaches do we have? We have the traditional approach, the hysterectomy, which is 100% effective, but it's invasive, it's expensive, and it's fraught with possibility of numerous complications. As a result, one tends to move towards the minimally invasive approaches. The minimally invasive approaches are less effective, but reduces morbidity. What do the minimally invasive surgical procedures do? They are designed to destroy the endometrium to a depth of about 4 to 5 millimeters. There are two generations, I have three, but there are two generations of ablative devices, all of which try to improve on the previous generation efficacy, duration of training, skill set, flexibility, and how morbid the procedure is. The first generation tools involve laser endometrial ablation, rollerball ablation, resection of the endometrium using the resectoscope. And these first generation kits require the use of a hysteroscope and a distending medium. We tend to use glycine very frequently. However, it is fraught with a number of potential complications. In fact, it can be fatal. And the second generation, which involves like thermal balloon ablation, hydrothermal ablation, biopolar frequency, microwave endometrial ablation, and cryo-endometrial ablation. Also, I'll add to this NovaSure as well as Thermoblate as two second-generation ablative devices. So second generation, we have microwave endometrial ablation, laser intrauterine therapy, cryoablation, MyoSure, and Thermoblate. I will just show you a brief clipping of the two first generation ablative devices. So just excuse me for a minute. So here is the roller ball in operation. So looking inside of the uterus, both tubal ostia here, and then the roller ball comes through.
See, Harris, we're not seeing any videos.
You're not seeing anything?
We're not seeing anything now. I think you have to, you have to share it as well.
Okay, okay.
So if you share the video, you have to share it instead of your presentation, because you cannot share two things at one time.
Are you seeing anything now?
Yeah, and we're not seeing any video now. Oh, now we see it. Now we see it. Well done. Now we see it. Yeah, it's on YouTube. Brilliant. Start from the beginning. Okay. Yes.
Okay,
yeah.
So here we have the roller ball in there, and it shaves the endometrium. This shows a depth of about 4 to 5 millimeters. The important thing in all of this is that you never push the roller ball away from you in contact with the endometrium. It always is brought towards you. Because if you push it away from you, there's a strong risk that you can perforate the uterus. So I prefer not to do that. Now,
repeat that. Can you repeat that video? Because it's a short video. Can you just repeat it for the audience? Just
okay, let's see if I can find it again.
And there's the chap there also. I think that's for, yeah. Can you just go from the beginning? Yeah.
Okay, roller ball ablation.
Oh, brilliant.
So this is the receptor-scope, sorry.
That's the loops, yeah, yeah.
Is that the loop? Yeah, receptor-scope.
It's all right, it's still all right, yeah, it's still all right, yeah, carry on.
That's how it works. Okay. The problem with that, sometimes the bit of endometrium that you have resected gets into your view and makes the procedure a little more tedious. But when it works pretty well. Okay, so those are first generation tools.
Exactly. So you have to now we'll start sharing again with your presentation.
Okay.
So you stop with one, you start with the other one. Yeah.
Okay. Now I'll show you two second generation ablative devices that we use. This one is called the Nova Shore. And this is basically the device that it comes with. This is plugged into this outlet, and the controls here tells you everything in terms of the depth of the uterus, the width of the uterus, and so on. This is the sound that you use to initially sound the uterine cavity. Once you insert it into the uterus, you then open it by joining the two handles together. So when it's open, it looks something like this. And then you drive a radio frequency current through it, which again destroys about 4 to 5 millimeters of endometrium. So that's what happens with the Nova Shore. It tends to work over 90 seconds. So when you look at the first generations, this is much more time friendly because within 90 seconds, the woman has been treated. So because of its short duration of use, it is used with local anesthesia and sometimes without any anesthesia in the office setting. So it is very convenient. And it doesn't require any long period of training. It's a short, you see it once, in medical school, they tell you, see one, do one, and teach one. So you could see one and then do the other one. Okay, all you need to do is to be able to access the uterine cavity. And the instrument itself has some safety devices. When they check the integrity of the cavity, make sure you haven't perforated. There's a puff of air, which it sends out to the uterine cavity, and it needs to return to it within 4 seconds. If not, the integrity test fails. So yeah, this is one of the more commonly used second generation ablative devices. And in fact, some people refer to it as a third generation ablative devices, but there's no such thing as that. It's first and second generation we have. So that is the Nova Shore. This other one here is the Tumor blade device. It's shaped like a little gun. We sound the uterus first, and then we insert this balloon catheter in there. And then there's fluid warming up in here, which is usually dextrose water, and it's driven into the balloon. The dextrose water is driven into the balloon at about 220 millimeters of mercury. So when it's set up, it looks something like this. So this is the sound here, and this is the balloon fitting, the tip of the balloon fits across the fundus of the uterus, and the balloon which rises down to the internal os of the cervix. All the directions as to what you need to do is fitted in this. All right. And once it lays against the endometrium, the temperature between the balloon and the endometrium is maintained throughout the procedure at about 100 degrees Celsius. The treatment cycle is about 2.5 minutes. So in the Nova Show, we have 90 seconds. In the Thermoblade, we have 2.5 minutes. So it's much more time friendly than either of the first generation devices. And finally, we talk about a hysterectomy. Now in the UK, we tend to practice less is more. And as controversial as that may be, the less invasive a procedure is, the better, providing you get a good result, right? So we tend to reduce the number of hysterectomies. And patients who come in for benign pathology are usually treated with one of these ablative devices, right? If they have any sinister pathology, like even endometrial hyperplasia, if it's of the complex variety, then they would of course require hysterectomy. And even that is done now with minimal access endeavors, like a TLH, a total laparoscopic hysterectomy, or even an LAVH, laparoscopically assisted vaginal hysterectomy. But there's very few people who practice the traditional hysterectomy in the UK. That is one of the big incision above the symphysis pubis. All right. So in conclusion, the younger age groups and nulliparous women, we talk about progesterone between day 5 and day 26. That's known to be effective. In the parous patients without fibroids, the Mirena intrauterine system is a suggested device. Why without fibroids? It is felt that if the Mirena intrauterine system is going to fail, the presence of fibroids is more likely to be associated with failure. In older patients with benign, and I stress here benign, endometrial pathology, a hysterectomy, hysteroscopy, and removal of the lesion, that if you can see it, like a polyp. Now, I should pause here to say that what we have found is that the tip of a polyp may be benign, but the base may be malignant. So it's important that when you are trying to remove a polyp, you remove as much of it as possible. Then you talk about a myomectomy. If, for example, the patient has a type 0 or type 1 fibroid, taking the fibroid intravaginally is probably the preferred option. Like I said before, oral progestins can be used. The Mirena if the patient is parous, and as an option, we could also refer to the use of the endometrial ablative techniques. Thank you.
Thank you very much, Mr. Philip. Very lovely presentation, full of orange. I was so impressed with it, really. And then I like these videos in between as well. Very nice of you. So what I need you now, just stop sharing so that we can go to the next and the final stage of our webinar. So go stop sharing.
Yeah, you want to see me no more, all right?
Yeah, I want to see you, in fact. Not that.
All right.
Well, thank you very much. So now we come into Q&A session. Before we go to the audience, I sent a message to everybody right now here. If they want to switch on their video on and then ask a question, I don't bother, just raise your hand. There is a raise hand thing, and you can ask the question yourself, face to face with the speaker. Until somebody brave enough to do it, I'm going to ask a question myself. So, Mr. Philip, he talked about his hysterectomy on a young girl, age only 21. And tell me, how did that happen? What are the issues involved at the time? And did you have any ethics issue involved? Unmute yourself. Harris, unmute yourself.
I'm doing that now. Okay, the story was, this 21-year-old girl presented with fibroids of the size of about an 18-week size pregnancy.
Yeah.
She felt she was complaining about pressure symptoms and her clothes feeling tight around the waistline. So because she was 21, we offered her a myomectomy. What she didn't tell us was 3 years earlier, she had a myomectomy in Miami. And the guys there found out that she had a bleeding diastasis.
All right.
So apparently they didn't communicate that to her, or she didn't know, or she didn't remember. So when we found it difficult controlling her bleeding, we contacted them by telephone.
Really?
And yeah, by telephone. And while she was still on the table, they were able to find her records and come back to us and tell us, yes, she has a bleeding diastasis. Now, during that time, she had lost about 3 liters of blood already. You know, so we spoke to other consultants and made sure that we had a few colleagues who were on board with the decision. And it was agreed that to save the woman, we should go ahead and do a hysterectomy. So we did that. She made a good recovery and she's well.
Okay, so that's very interesting because the youngest I was involved with as a hysterectomy was a lady who was 34. I don't know what about you, Mehsen. How?
Yeah, one year, I think 25 years ago, we did a hysterectomy for a single patient who don't respond to any measures. All measures fail to treat the patient. You know, sometimes we face problem in Iraq. Single unmarried girl, they never accept interference with hymenectomy. They never accept for any reason. Even if they have a cervical polyp which lead to severe bleeding, they never accept to do. They never accept hymenectomy. That's why we are sometimes even we open the abdomen and we open the uterus and we cut the polyp from the inside the uterus. You know.
Really?
And then yeah, they never accept this procedure. Even they are reaching 60 years of age. I have one patient, 60 years. I won't tell her what you are going. What about the integrity of family? What is makes for you integrity? The family, they never accept that. So I think 20 or more than 20 years ago, I did hysterectomy for the same age, possibly Mr. Phillips mentioned, 20, 21, 22, like this. It doesn't respond to all measures. I would say something actually, because I gave the lecture without writing all notes in the slides. We did the Marina for, we usually use Marina 10 years ago for those patients with the bleeding, actually after exclusion of organic causes of bleeding. MyoSure nowadays used in Al Musawi Hospital. And actually, yeah, it is used.
You mean in NovaSure?
NovaSure, sorry.
NovaSure, yeah. Me and Prof. Haloub, we came, Manal just remind me, probably 6 years ago, we bought the machine with us, the NovaSure machine. And we bought with us a few kits and all that. The problem, Harris, if you done NovaSure before, NovaSure can be very tricky sometimes. If it doesn't, if the pressure doesn't build up because of a leak, then it stop working, doesn't allow you to carry on the procedure. So no matter what you do, left and right, doesn't start off because of the safety mechanism. Because if the pressure doesn't rise, it gives the impression to the machine that there is a perforation, so it cut off. So now the kit you use is wasted. That's mean 200 pounds or 300 pounds, you know? That's the thing tricky about NovaSure. The thermobilate, the one like a gun, that is much easier to use. The one after that, that's much easier to use technically. And I never seen it fail to trigger. With the NovaSure, you can do sometimes very perfect job, you think, and you do the measurements and you do everything, but it doesn't start because the pressure, there is a leak in the pressure and the machine read it like there is a perforation. So it stops the machine automatically. That's the NovaSure. But
sorry.
Yeah, you remember that.
Sorry.
Do you remember, Mehsen, that when we came like 5 years ago?
Yeah. You know, Ali, before I would say in 2003, when I was in UK, I just attended in Great Portland Hospital, transcervical, the first transcervical endometrial section IC in 2003. It's done by Macmillan in Great Portland Hospital in Great Portland Street in UK.
Yeah.
That was, say, 20 years ago.
Yeah, but now, you know, that now is done in Iraq. يعني me and Rahim, we came a few times, and now they did, like the ladies, the girls in Baghdad, Bil Basra.
Yes, they do it. Yes, they do it.
Ali Al-Asadi, he do it. He got, I gave him one I bought with me, hysteroscope, resectoscope. With me, and now he's been using it now for the last 10, 15 years. And he showed me every time he resect a big fibroid. And now he's the expert in that. Absolutely. So the practice is picking up, but I think the ladies gynecologists, really, they are very good in Yarmouk, I tell you. They picked up and learned the technique very quickly. But the problem is the maintaining the instruments. The problem in Iraq, after a few weeks, a few months, something is broken. The machine, the stag, or the loop, or the thing, the handle, and then nobody uses it again, and gradually people get de-skilled, and they have to start again. So Manal Aini, do we have any question from anybody? Manal?
Yes, I'm here.
Yeah, you still here? Yeah.
I have Amir. She wants to ask her question.
Yes.
Amir, are you with us? Amir, I have a list of patients. Many of them, they couldn't get in. They said that they have problems with the internet and with the Zoom.
I just unmute her.
Yes, Amir.
Let me unmute her. Let me unmute her.
Amir, okay. Amir, could you? Amir, just click. I ask you to unmute. Amir, بس سوي unmute.
هنا قاسم.
يعني الصوت unmute.
Why she doesn't ask you the question? Let her ask you the question.
فتحتي unmute؟ وانا طلع لي unmute. لا بس طلع لي unmute وسويتها هاي.
هي next to you, Manal? Is she next to you?
Next to me, but she couldn't unmute herself. دكتور سوي unmute for all بس برخصتك يعني من يمك دكتور علي.
Do you want me to unmute all?
Yes, please.
مو اكو احتمال it become a disaster.
ما يخالف احنا نغلق من يمك.
Do it.
If I unmute you, there may be a chaos coming, you know.
السلام عليكم أمير وياكم.
hello عيني. شنو القصة؟ أو can we help you عيني؟ شنو القصة؟ احكيني.
أنا من عمر يعني 14 سنة.
اي
المانث سايكل يعني كانت تجي مش هواية.
اوكي. خليني بس اترجم للدكتور حارس.
10 أيام.
عيني امير بس انتظريني انت احكي وانا اترجم حتى الدكتور حارس. Harris, this is a lady who's from the time she was 14. Her period was very, very heavy. كملي أمير.
5 أيام يعني heavy. ورا ما تبدي تقطع يعني.
إيه.
تستمر 10 أيام. طبعاً وياها pain. خاصة أول يومين 3.
زين كم يوم تستمر العادة مالتك؟ كم يوم؟
10 أيام.
So her period.
ولحد الآن 10 أيام.
Okay, her period always 10 days, Harris. So is it عندك clots يعني خثر و fresh blood ولا شلون يعني؟ تغرقين نفسك بالدم؟ أمير؟ إيه؟ كملي الحكي عيني كملي. Hello. منى بعدش موجودة؟ ما نسمعك ترى. ما نسمعك الظاهر muted yourself.
السلام عليكم.
هلا عيني، من المتحدثة؟
دكتورة منى قاسم من كربلاء.
هلا دكتور. Okay, دكتور, carry on please.
دكتور, يعني I want to talk about my patient. She is 53 years age, female.
Yeah.
She had history of CA cervix, operated on.
دكتور علي تتكمل أم أمير وياك؟
لا خلينا نبدي ويا الدكتورة ونرجع على أم أمير. خلينا
ماشي. بس دكتور من لما تسوي امن ميوت ولا اي شيء صوت نسمعه احنا نسد، لان هو من يمنا لازم نسوي ان ميوت فور ذم، متى ينفتح يمهم انا اسوي ان ميوت.
اوكي مو مشكله. دكتوره كملي حكايتك يعني دكتوره.
بلي يعني she received chemotherapy post surgery and she did previously bilateral oophorectomy according to surgeon opinion. Now she is presented with postmenopausal bleeding.
How old is she?
53.
53. Okay.
Endometrial thickness by transvaginal ultrasound 4 millimeter. Pap smear is normal.
Okay.
How can we help her?
So let's just summarize. Annie Muna, she is 53.
Yes.
She got heavy postmenopausal bleeding.
Yes.
So endometrial thickness is 4 millimeter.
Yes. Normal pap.
So what is the worry?
Because she had a previous CA cervix and she take tamoxifen CA breast, yes, and take tamoxifen for long period. Belly.
So she has a CA breast before, but what she just had a mastectomy or something. What did she have?
Mastectomy, and she received chemotherapy and they put her on tamoxifen and for long period.
So she been on tamoxifen for how long?
5 years.
5 years. يعني بس هي بالنسبة لها endometrial thickness on tamoxifen 4 millimeter. There is no. What is the worry? 4 millimeter is all right.
What about her spotting? I am afraid from the spotting.
Okay, I leave it to the speaker to decide. Yeah, Mr. Philip, what do you think?
Well, the patient, as far as my understanding goes, has been treated for cervical CA. She has had radiotherapy. She has had chemotherapy.
Not cervical, sorry, Mr.
No, Harris, it wasn't cervical. It was a breast cancer.
Breast cancer. Okay. Yeah. Well, she has been on tamoxifen, which is known to have an pro-estrogen effect on the uterus.
Okay.
So you'd have increased incidence of endometrial polyps and even endometrial hyperplasia and endometrial cancer.
Yes.
You would need to have a conversation with this lady, because what we do not know is how long the effect of tamoxifen will last. So although she may have stopped the tamoxifen last year, we don't know how much longer the tamoxifen will have its effect.
She had a scan, and the scan showed endometrial thickness of 4 millimeter. 4 millimeter.
Okay, Ali, not blowing my trumpet too much. There are 2 studies in world literature which talks about endometrial cancer being picked up on endometrial thickness of 3 millimeters.
Okay. So
it's done. One was done by an Oriental guy, and the other one I did the other study. So there are 2 bits of information in the world literature which talks about that. Now, if this lady has a setup that exposes her endometrium to prolonged use of estrogen, again, I'm saying that we don't know how long the tamoxifen is going to affect the endometrium for. So in that situation, my option would be to either use the Mirena intrauterine system on her or to discuss a hysterectomy with her.
So, Dr. Muna, did you hear that?
Yes.
خليني بس أسأل دكتورة منى. سوري دكتور علي. دكتورة منى, do you hear me well?
Yes. تفضل دكتور.
Because you mentioned that the patient have got bilateral oophorectomy. Am I right?
Yes.
Yeah. Did she took any sort of hormone replacement therapy because of this procedure?
No, she did the oophorectomy before 1 year. يعني when her age was 52.
Yeah, before 1 year she had it.
Yes.
Did you see the bleeding is exactly from the uterus? Possibly she may have. Possibly she may have from urethra or from the anal region, because
no. By speculum examination, the blood came from
the cervix.
Yes.
Yeah, yes. It's uterine, you mean, in origin.
Yes, yes.
It doesn't seem to be any problem in her uterus. Actually, 4 millimeter thickness endometrium, you don't expect to find the possibility of carcinoma of endometrium. Although there's certain,
Yeah, but
although sometimes,
you know what Harris said? There are rarely cases can happen. What he said, well, I don't know, Muna, Harris' view that if you want to be 100% sure, offer her to have a Marina coil. Marina would protect her lining, would suppress her lining, and obviously, what else? You can do hysteroscopy and biopsy. Go and do hysteroscopy and biopsy. Make sure the cavity is fine. There is no funny polyp hidden somewhere. And after that, if you're happy at the end of the procedure, put a Marina coil in.
Yes, thank you very much. Thank you very much.
Manal, where is your patient? What's her name?
Amir.
Amir. But I cannot find anybody in the participant called Amir.
أمير موجودة دكتور. أمير موجودة.
شنو يعني الاسم مالتها أمير؟
Yes, in Arabic. She wrote her name in Arabic. Amir, last one.
عافية. Okay, I'm going to unmute. I am unmuting her. Yeah, I am unmuting her. Ask to unmute. Ask to unmute.
She should do it. She should do it.
بس هو she can do it, Bob. I cannot do it on her.
I will ask her to speak from my phone.
إيه خليها speak from your phone. Yeah, it's all right. Yeah.
نعم دكتور.
هلا أمير. عيني أمير كم لي حكايتك؟ يا كم لي حكايتك؟
أي بلي دكتور هو يعني أنا بليدنج 5 أيام وهي تستمر الدورة 10 أيام.
أوكي.
بس تبدأ تقطع بآخر 5 أيام.
أوكي. إيش قد صار لك إيش قد صار لك؟
من عمر 14 سنة.
من عمرك هسه إيش قد عمرك أنتِ؟
أنا هسه عمري 35. بس ممكن أحكي لك هيستوري يعني؟
إيه اعطيني هيستوري.
أنا قبل 10 سنوات صرت بريجننت.
أي.
وصار عندي هاشيموتو ثايرويدايتس أوتو إميون ديزيز.
أوكي.
واستمر يعني بعدني المانث سايكل 10 أيام.
أي.
وأول 3 أيام بين كل شيء يصير عندي قوي.
أي.
وتستمر يعني 3 أيام بليدنج. ووراها تبدأ تظل تقطع لمدة أسبوع.
إيه.
شو هيك؟
الهاشموتوس مالتك how is the هاشموتوس now؟ يعني ايش عندك under active شلون الغدة مالتك؟
هايبوثايروديزم.
انت هايبو هسه. زين
يعني اول ما بلش الهايبو عندي يعني التي اس اتش كان يقرا اكثر من 60.
اوكي. تي اس اتش يقرا اكثر من 60.
نعم.
اخ هاي شنو هاي شلون هايبو هاي؟ ايش قد تاخذين ثايروكسين؟
حاليا دا اخذ 125.
Okay, so Harris, if you the thing goes like that, this lady, she been having heavy period for many years. She also got Hashimoto thyroiditis, which was treated. شلون عالجوا الهاشموتوس مالتك ايش سووا لك؟
الثايروكسين.
ثايروكسين.
عندها right now she got underactive thyroid, very severely underactive, and she's taking 125 microgram of thyroxine a day. زين.
دكتور دائما الفيرتين الفيتامين دي دائما يطلع عندي نازل.
Okay. Always low ferritin and vitamin D. زين قولي لي انت هسه ايش تستعملين للعاده مالتك؟ شنو العلاج اللي تستعملين؟
ما كل شيء ما دا استعمل.
ليش؟ على اي اساس يعني؟ اذا انت عندك هيفي بيريود غير لازم تستعملين في الشغله يعني ما معقوله. زين بالنسبه للمارينا كويل فكرتي بيه؟
شنو هو دكتور ما سمعتك دا يقطع الصوت.
هذا اللولب المارينا اللولب.
لا.
ليش؟
يعني ما حد قال لي على اللولب او
زين
يعني اتأذى بأول 3 أيام بليدنج ووراها يعني تبدي تقطع يعني ما يعني قلت لك دكتور صار لي سنين على هالوضعية يعني ما صار انه فد قرار انه
Amir, let me go to the speakers and ask their views.
دكتور علي بس خلي اسال أمير.
يعني
أمير, when was the last time وقت آخر مرة سويتي thyroid assessment, thyroid TSH
قبل أسبوعين.
ايش قد طلع على T34 تيست؟ قد طلع TSH؟
طلعت 11.
ادري يعني definitely اني hypothyroid يعني the cause is known يعني انت اصلا مشكلتك مرحلة يعني قلة هرمون الثايروكسين يعني هو هذا الاساس يعني اول شيء واحد يفكر بعلاج السبب يعني احنا قبل لا نعالج المينوريجيا اللي عندك والبليدنج اللي عندك لازم تعرفين انه الكوز فور ذا بليدنج از هايبوثايرويد. زين برولاكتين سويته
طبيعي
يعني it seems unlikely يعني الهرمون هو اذا يطلع التي اس اتش عالي 6 ترى كلش عالي يعني ماكسيموم 3.4 اكسبتد يعني من يوصل 6 معناته الثايروكسين لو مالتك يعني المفروض انت تراجعين ابو غدد صماء you just consult endocrinologist to check your thyroid state so that if you came يعني euthyroid مرحله euthyroid definitely the cycle you will improve your symptoms will be improved.
دكتور يعني هي فتره يعني استقرت عندي على الايوثايرويد تقريبا 5 سنوات.
شنو اللي صار من صرت ايوثايرويد؟ لا من صرت ايوثايرويد شنو اللي صار فرق لو ما صار فرق؟
لا ما صار فرق
يعني
بالنسبه للبليدنج والدوره نفسها ما تغير عندي شيء ما تغير عندي شيء
نفس الوقت.
Okay, Professor Bach. And Mr. Philip, what do you think? Summary of her case. She's a case of underactive thyroid. She's been treated with thyroxine for a long time. When she became euthyroid, her bleeding was still heavy. She still have heavy period. She hasn't used any medication just yet, and she wants an opinion. Unmute yourself, Harris. Unmute yourself.
That's a lot of work, man. Muting and unmuting and so on. Okay. First, I would address the thyroid dysfunction. You know, do a thyroid assessment, see where we are in terms of a control. You said she's euthyroid. If she's really euthyroid, the bleeding should have settled unless there's an organic lesion.
It hasn't settled. That's what she said. Even when the thyroid function was normal, she was still having heavy period. What do you do for her?
How old is this lady?
ايش قد عمرك أمير؟
35.
35.
35. Our family is finished? It's complete?
ما تريدين جهال؟ خلصتي؟
لا طبعا أنا أريد أطفال.
She wants more children today. يعني.
Well, I would use the Marina is what we have to use, or else we could use oral progestins.
عندكم انتم بالعراق البروفيرا أمير؟
نعم.
ليش ما تستعملين البروفيرا؟ قولي الدكتورة منال تعطيك بروفيرا تابلتس وفيري افكتيف.
استعمل البروفيرا.
اي البروفيرا رخيصة cheap effective وavailable in Iraq I know for sure يعني الشريط ب20,000 يعني.
The problem though.
بالنسبة للحمل يعني أنا مأخرة الحمل بسبب الثايرويد يعني أكو مشاكل ممكن.
الحمل طبعا هو انت لما توصلين تصيرين euthyroid يعني your fertility should improve. You should automatically be able to يعني يصير عندك baby. والبروفيرا مو مانع. Provera is not contraceptive. Provera is just to treat the symptoms of the period. يعني فأنت you still remain fertile on a Provera. يعني تاخذين البروفيرا وبعدك ممكن تحاولين البيبي. عرفتي؟
تمام.
اوكي يعني.
اوكي شكرا.
تدللين.
شكرا.
Any Manal, do we have any more? Manal?
Yes, I'm with you.
Hey, Annie, what do you have on your side? Do you have more people?
Yes, I have. I have a list of patients, and Fatma Mohammed, I don't know if she is here or not. Fatma? Okay, bring the medication. Marwa, can you unmute Marwa, doctor? Because
Marwa, let me. Tara, I tried to unmute Amir. I couldn't. Marwa. خليني أشوفها وين مروة.
Raise your hand, Marwa.
Marwa, raise your hand, Marwa. أشوف ماكو مروة. وينكم؟ أدور على الإمز. والله.
I think we have Noura Sabah raising her hand. Noura Sabah. دكتورة نورة.
هي نورة شفت واحدة.
دكتورة نورة Sabah, she raised her hand. She raised.
Okay.
Good evening, everybody.
Good evening,
Hello.
أهلا حبيبتي. دكتورة نورة. دكتورة نورة رئيسة قسم النسائية بكلية الطب جامعة كربلاء.
كل زين. Yeah. Okay. We have a colleague here. Brilliant. Yes. Yeah. Come on down. Come on.
I'd like to thank all of you because for organizing this nice meeting, and I would like to thank the professors for their nice and informative presentation. I want to ask a question about a patient. I saw her in the last week. She's 56 years old, post-menopause she was menopause for about 5 years. She had no symptoms regarding any gynecological problem, no pain, no vaginal bleeding, even no discharge. She went for doctor to do ultrasound for her abdomen and pelvis for checking, and accidentally the sonorist report that she has endometrial thickness of about 14 millimeter, and he's one of our colleagues who is efficient. So I did for her endometrial biopsy, and the biopsy was there is no endometrial hyperplasia, no signs of malignancy, and it was completely normal.
All right.
So I told her that I can follow her for ultrasound every 3 months, or better to put her on Mirena to be a preventive measures for any recurrence of the endometrial hyperplasia, which was just by ultrasound.
But there is no hyperplasia, Annie. Hyperplasia is a histological diagnosis. Is not ultrasound diagnosis.
No. The histopathology, there is no hyperplasia just by ultrasound. And even the picture of the ultrasound, really she has endometrial thickening, which was abnormal. So
how old is she? How old is she?
56 years old.
Okay, so she 56, not on HRT. She got endometrial thickness of 14 millimeter. Does she have postmenopausal bleeding?
No.
She had no.
No postmenopausal bleeding. No. What you want to do for her? I tell you, let me just ask Harris. Harris, what do you think? How do you manage this patient in UK?
As a minimum, she needs a hysteroscopy.
Exactly.
Where we look into the uterine cavity and see what's happening and get, if possible, a focus biopsy done. Anything that looks unusual, we try to biopsy it. If the biopsy comes back as being benign, then the option would be to use a Mirena in her. And every year you reassess her endometrium. But it would appear that she has an extraneous supply of estrogen. Why is the lining of the woman's thick as 14 millimeters? That is usually in keeping with endometrial cancer.
14, not 40, Harris.
14, 1-4. Yeah.
Yes, 1-4.
Yeah, so I would hysteroscope her, take a biopsy, a directed biopsy, and see what it comes back as. If it comes back benign, I would put a Mirena in, and every year I would bring her back for surveillance.
So if the patient refused Mirena and I want to put her on oral progesterone, what is the dose of oral progesterone?
No. If you put her Mirena, you don't need oral progesterone.
No, she refused Mirena. I told her about Mirena. She refused.
She refused the coil.
Yeah.
Okay.
The dose of oral progesterone.
Yeah, you can give her Provera, but it has to be big doses, darling.
High dose is 100 milligrams.
Yeah, like 100 milligram or 70 milligram. Big doses has to be.
But then you run the risk of side effects, breast tenderness, bloating, low moods, that kind of stuff. So as such, the patient needs urgent, serious counseling. Let her understand what she's asking for and what the likely effects are going to be. Okay, because with that high dose, the side effect profile becomes more prominent.
Yes.
Whereas the Mirena would be an easy way out.
Yes, that's right.
Let us see how محسن how you manage her محسن.
دكتورة نورة، هو بالحقيقة يعني ما أعرف طبيعة السؤال، يعني أنا فقط عندي يعني objection إنه أنت you said that there's thickened endometrium 14 ملم. طبعا هذا مو هيستولوجيكال، هذا مو التراساوند، يعني الالتراساوند مو هيستوباثولوجي حتى يقول. ممكن نقول يعني هايبربليجيا تعني increase in the number of the cell، يعني it should be done by histopathologist because hyperplasia mean increase. Hypertrophy ممكن نقول you may say because the size is increasing in hypertrophy. هذا رقم واحد. الثاني it seems unlikely that يعني patient with hyperplastic endometrium treat to the degree of 14 millimeter, 14 millimeter, and she is 56 years of age, and the result of biopsy say no hyperplasia. اكو في discrepancy بال still اني حتى وين حصل هذا الشيء. طبعا I quite agree with Mr. Philip what you mentioned by hysteroscopy directed biopsy. Possibly you might find certain pathologies, certain abnormality. يمكن إذا نسوي DNC ناخذ من أكثر من مكان واحد. إذا واحد مو expert doing الهيستوري ممكن ياخذ biopsy من أكثر من مكان واحد to be sure. Sometimes it's not easy to take the biopsy. أما الكيوريت is not sharp أو شغلة ما يطلع good. يعني it doesn't seem likely that you find the thickened endometrium 14 millimeter and the result says you have normal endometrium. اكو في discrepancy يعني بين المختبر وبين البايبسي الماخوذه. شكرا.
The problem though is that a polyp may have been missed. So what shows up as 14 millimeters may in fact be a polyp around normal endometrium.
Absolutely.
So that's why the hysteroscopy would help to clarify things.
Absolutely. Yeah, because this is it can be Dictora, this is all can be because of a polyp. And the polyp, you know, when you do endometrial biopsy, blind biopsy, you're only biopsying 6% of the cavity. Six. Imagine. So you have to be so lucky to get, if it is a polyp, to get to the polyp or anything. So she needs hysteroscopy, please. Hysteroscopy, you can do it in Basra. There's so many hysteroscopists now in the south. We train them and all that. So it's not a big operation, it's a minor operation, in fact. And she can go home on the same day.
Okay, thank you very much.
No problem, Annie. No problem. So, Manal, anybody else?
Yes, I have a list of patients. I don't understand why they couldn't answer me. I will just, in hurry, I will say their names. Okay,
you know the story, tell us the story.
Fatma Mohammed, Fatma Hussein. I didn't notice their name. Fatma Mohammed, Fatma Hussein. ماشي. بنين عدنان وريهام. بنين عدنان وريهام.
I can't see their names here.
ومروة ورانية. مروة ورانية.
زين وينها مروة? Why doesn't she call you on the speaker? Let's call you on the speaker.
ما أعرف، يظهر إنه أكبر مشكلة يعني ذلك ما فاتوا، يعني هي الأسماء كلها كانت موجودة عندي بس ما دا ألقاهم، يعني يظهر أكو يعني باللوج إن صارت عندهم مشكلة.
Okay, let me just see because I have here some messages, 9 new messages.
Okay.
Okay, هاي نفس الدكتورات الدكتور اللي حكينا وياه same one يعني. Okay, so yeah, that means there is no more, Manal?
Yes, no more question.
No more question. Okay, yeah.
Can I ask you some question?
Of course, yes, of course.
Okay, I have a patient. She did a hysterectomy, I think 1 year ago, and then she did subtotal hysterectomy, and then she noticed vaginal bleeding, spotting, just spotting. When she presented to me, she have a mass from the cervix, and it is fixed. The ultrasound revealed this man is extended to the bladder.
No.
Okay, But it is very friable. I couldn't even take a biopsy from it. When I touch, severe bleeding come. So how can I take a biopsy from such a lesion if there is a severe bleeding with even mild touch, with even a piece of cotton?
Okay, let Mr. Philip answer you. Harris, if you have this lady in your clinic, what do you do for her?
Well, she needs a biopsy to know what type of tissue is it. Where is the mass coming from? So there's a paste we call Monzel paste, which should be effective in terms of
severe bleeding.
What Monzel paste? Do you have Monzel paste?
Sorry?
Monzel paste, M-O-N-S-E-L.
No, we don't have. I see it in the through the Google. We don't have that type. Yes.
Okay.
So
yes,
so if you don't have this Monza thing, what do you do?
What can I do?
What do you
just
do?
put it on.
You can't
It's just sulfate.
Small coating.
Would compression work?
Compression? So I take a biopsy and I put it back and leave it.
Put pressure on the lesion until the bleeding stops. You might want to use also, I don't know if you have this powder we use for laparoscopic bleeding.
No, that they don't have this powder.
They haven't got that.
There's special powder. Yeah, there's expensive powder.
Options.
No. Manal, be practical about it. You need a biopsy.
Yes,
so
of course.
The best thing, if you want to have a biopsy, do it in theater under GA.
Yes, of course.
حتى الدايثيرمي يمش موجود، السوالف موجودة. If you take a biopsy and if you bleed in theater, you have the diathermy, use the handheld diathermy and burn until it stops bleeding.
It's like butter. It's like butter you just chase through.
Hey, and if she's still bleeding,
yes,
pack the vagina for 24 hours with antibiotics. It should stop. It's not a disaster, but leave a pack in her vagina for 24 hours, put a Foley catheter, حتى تقدر تبول. Well, after 24 hours, take the pack away. It should stop the bleeding. But if you're suspecting cancer, she needs MRI as well. She might have, have cervical cancer.
I sent her.
So she needs MRI just to check where is this thing going.
Cervical lesion extended to the bladder.
يعني essentially what she needs, they call it EUA, examination under anesthetic. EUA, examination under anesthetic. يعني مو مع قضية clinic in the you do it.
لا طبعا اصلا تخاف وين تقبل لا.
I would suspect before she has the subtotal hysterectomy, they would have checked the cervical smears.
They don't do cervical smear in Iraq, Harris. They don't have.
They don't do it.
They don't do it. No.
Oh gosh. Okay.
هو البروبلم هي صارت موضوع مهم جدا دكتورة منال.
نعم.
يعني المفروض احنا يعني the only indication for subtotal hysterectomy is negative cervical smear.
Yeah.
The patient should have, if she wants to keep her cervix for any reason,
of course,
she's still sexually active women, you should be sure that there is negative cervical smear. This is the problem. I think the one who opened her, he faced the problem. And it's difficult for him to complete the procedure. That's why he just sutured at the level of the cervix, internal os, and he closed. أعتقد إنه المشكلة, the problem is not happened when after hysterectomy. The answer is definitely no, because if she had mass and there's involvement of the bladder, that means this need at least 15 years to reach.
Maybe the problem was primarily from the cervix, but they didn't check.
Yeah, I think they did the hysterectomy without checking the cervix.
Checking the cervix.
They did, they opened the abdomen and they faced the problem. They faced the problem. They see the uterus was fixed, it's not easily to be removed, and they just took up the bulk of the uterus and they keep the cervix as from the internal os and the suture.
Okay.
I think this is what happened exactly for this patient.
Thank you, Mohsen. I have a raised hand, Naif Ali. Naif Ali, you can speak. You can unmute yourself.
Ali Naif.
Ali Naif, yes.
Thank you so much, Dr. Mohsen, Dr. Ali, Dr.
Habib,
Harris, for interest.
yeah, tell us exactly what you want to ask.
هذا الصوت ما واضح عندي.
You hear me? You can hear me, please? What
No,
are
no.
the pathophysiology of thyroid dysfunction in menorrhagia? Dr. Mohsen, hear me, please?
نعم هو نعم.
Dr. Mohsen, thyroid dysfunction include hypothyroidism, hyperthyroidism, subclinical hypo and hyperthyroidism. What are
هو الثايرويد نعم هو
physiology of thyroid dysfunction in menorrhagia? Cause menorrhagia.
Yeah, definitely. The best thing is that you mentioned that thyroid disorders. Actually, it is thyroid disorder. Hypothyroidism more lead to menorrhagia than hyperthyroidism. You know these hormones يعني هو اصلا الهرمون disturbance is a cause. يعني ما سامع مرة تقولون اضطراب بالهرمون. Hormone disturbance is the major cause for irregular cycle. الثايرويد function مهم جدا for regulation، جدا مهم. لما تيجي البيشنت هايبوثايرويد تتوقع المريضة تصير bleeding. طبعا السؤال انه انت تعرف حتى بالبريجننسي الثايرويد كانوا قدماء المصريين سابقا يشوفون الانلارجمنت اوف ذا ثايرويد جلاند with the pregnancy. يعني اذا شافوا اكو تضخم بالرقبه increase in the size of the neck that means the patient is pregnant. ليش؟ لانه الثايرويد ديماند يزداد مع البريجننسي. فاكو synchronization between the thyroid function and the cycle، بحيث انه البيشنت اللي تشوفهم هذا بالاضافه الى البيشنت اللي هم hypothyroid tend to be hyperprolactinemic، وhyperprolactinemia is a cause for menstrual disturbance. اتمنى وصلت الرساله. واذا
Thank you, Professor Bach. I think it's very clear probably now. Thank you. Manal, do you have any more questions?
Thank you. No, I don't have.
Okay. I think here we reach to the conclusion of our webinar. I thank you all really for your participation. Thank you for our speaker, Professor Bach, Mr. Philip, for your lovely presentation.
دكتور بس العفو انا اقاطعك. هذا جاوبناها اللي هي my cycle in adolescent 12 years old. ما اعرف جاوبناها. unmarried.
Which one, Manal?
On the chat.
On the chat?
Yes.
What is it?
She said, hello, my cycle since adolescent 12 years old is very heavy with the clothes for the first. She's unmarried.
This is the same lady with a thyroid problem, Manal. This is the same lady she spoke in and we talked to her.
But she
this
said
is the same one.
The one she talked, she is married, she have a baby.
Yeah, with that lady also she had a baby. She said about the thyroid, her thyroid issue, Hashimoto's and all that, and TSH of 6, exactly the same one, yeah.
Okay, maybe.
No, it's fine. We answer that. So Manal, thanks also for you. It looks like you are in the clinic in your ayada doing both jobs together. Thanks for the lovely presentation for Professor Bach and Mr. Philip.
I'm not the same patient. I'm not the same. هي دكتورة تقول I'm not the same. موجودة بالشات والله مو خطية.
خطية زين. Okay, let me just read it.
تقول I'm not the same.
Okay, if she's not the same, let me just read it. It looks like another patient. She said, my cycle since adolescence is very heavy with the clots for the first 4 days and then bleeding. I don't use any medication. I got normal thyroid function test. I'm 27, a still heavy period with the clots. Usually it's 7 days, but sometimes comes to 9 days. I don't have thyroid issue till 9 years ago. and now I'm cured for what? But last TSH was 6. Otherwise, the T3 and T4 are normal. I don't use medication, unmarried. So her TSH is high, but her T3 and T4 are normal. She got a heavy periods. She is unmarried. She is, main problem is her heavy cycle. So Mr. Philip, how are you going to help her? Unmute yourself, Harris. Unmute yourself.
That's hard work, man.
I know it's hard work.
Yeah. Progestins, oral progestins between day 5 and day 26 would be appropriate for her, I would think.
Okay, so Manal, did you hear that? The best thing, start her on a Provera, day 5 to 25, 5 milligram 3 times a day. That should sort her out.
It could be Provera or Nortesterone.
Or Norvesterone, or Norvesterone, one of them. I think they have it both in Iraq. Provera is available and Norvesterone is available, and they both don't interfere with her fertility. So she still can get pregnant and if she get married, you know, and all that. So I guess that's now, it's fine, Manal. You don't have anybody hidden anywhere, you know. Okay, it's fine. So now I can thank the speaker again for the 3rd time for being very nice speakers. And I was so honored to have both of you. And I thank Manal for all her hard work. And hopefully we meet again in the future in other webinars. God bless you all. Bye for now.
Thank you.
Bye, darling. Bye.
Bye-bye.
Bye-bye.